Yeah.
Hello,
Am I
sir.
audible?
A very warm welcome. Yes, sir.
Yeah. So I think sorry for the delay last time that we had a goof up. I hope today we are able to do justice to the subject, I believe. So can I share my slides?
Yeah, sure, sir.
Share screen.
But till then, just we'll have a quick introduction for you, of our speaker, like that's you.
Yeah, you already done it, my dear. It's okay. Don't need to repeat. Is my screen visible to all of you?
No, sir.
No?
No, sir. It's not visible. Yes, sir. Now
Now
it is
visible?
appearing, sir. Like it's good.
Yeah.
Okay, I'll just
Yes,
go
sir.
to
Now it's
the
Yes, sir.
visible.
Now
yeah.
it is
It's
visible.
visible.
Okay, I'll go to the slideshow now. Okay, go back. The video is, acha, my video is not on. I'm sorry. Okay. Okay, just a minute, huh? This is a very, very big file probably. So I probably have kept my presentation open 4 hours ago only. I thought it takes a very long time for it to start. Okay, so okay, so most of the students who are there, which year they are going to be, Aishwarya?
Like it is actually mixed. Like some of them are from second year, and there are even some students who have actually graduated out.
It's going to be a mix, correct? So I'll try to keep
Yes, yes,
myself.
sir. So actually, even the second year students, they must have covered heart failure. Like it's in the initial part of the syllabus itself.
Medication wise, they are all comfortable.
Yes, sir. They should be.
Okay. If there's any challenge, please stop me and probably we can discuss it.
Sure, sir. So
Okay.
usually they'll know, sir. That's not a problem.
Fine. Okay. So anyway, but maybe if I really go a little above that level, please halt me and tell me. I don't mind because I may not be aware how much. Okay. So let's start. Okay. Good evening, all the Pharm D students as well as the people who have passed out. I believe your specialty is very unique because you are the link between the doctor and the nurse predominantly. Because when we talk of pharmacist, I believe the role now has changed predominantly from just drug givers to even auditors and prescribers and a significant asset to any institute where probably you'll be even auditing the prescriptions which are there and drug interactions you're going to tell us. And I believe it's a great asset because my organization at Aditya Birla, we are obviously very much privileged that we have real good clinical pharmacists and we have a very, very good interaction with them. Okay. So now we will start with the medical management of heart failure. Try to understand definition of heart failure is a clinical syndrome characterized by typical symptoms, that is breathlessness, ankle swelling, fatigue, that may be accompanied by signs of raised pulmonary venous pressures or systemic venous pressures. So pulmonary venous pressure is systemic venous pressure is by JVP and edema and ascites. Systemic is by crepitations or auscultation, and it is caused by a structural and or functional cardiac abnormality resulting in a reduced cardiac output and or elevated intracardiac pressures at rest or during stress. This is very, very important. And you should understand that the big heart is a problem of ejection and a small heart is a problem of filling. You have to differentiate heart failure with reduced ejection fraction, that is EF below 40, Then there is something which is called as a preserved EF, where EF is 50 and above. And between 41 to 49 is called mid-range ejection fraction. Prognosis, you should understand that more than 50% of these people die at the end of 5 years. And look at the mortality. The moment my ejection fraction becomes below 30%, my mortality becomes almost 40%. The moment my ejection fraction is 50, my mortality is below 5% or 2% if you see. So this is very important from a clinical perspective, that somebody whose ejection fraction is 40 and below is at a very high risk of sudden cardiac death. Now, heart failure has dyspnea, fatigue, chest heaviness, palpitations. Atypical symptoms are fatigability, decreased urine output, nocturnal cough, and abdominal discomfort. Now, which are the high-risk patients? People who have syncope, acute decompensated heart failure like pulmonary edema, and worsening renal disease. Why this is very important? Because it will try to understand you as Pharm D students are also not only going to be looking at the drugs, but you're going to look at the patient also. That's why. What are the mimics of congestive heart failure? Let me tell you, 40% of patients of COPD who have been diagnosed by the physician or the pulmonologist turn out to be HFrEF. 40% of people who have sleep apnea can have significant pulmonary arterial hypertension. People who have renal failure with fluid overload can also exactly mimic heart failure. And somebody who has anemia, hemoglobin below 7 or 6, can also come to you with signs and symptoms of heart failure. Now, these are the approaches. You need to understand that stages of heart failure are divided into A, B, C, D. A is high risk for developing heart failure. That means somebody who has risk factors is at a position to probably, just a minute, Aishwarya, one call is there, just give me a second.
Yeah, sure, sir.
Hello, am I audible?
Yes, sir.
Yes, sir.
Yeah, okay. Stage B is by definition going to be somebody very, very important, asymptomatic, like somebody has an MI, LV dysfunction, or an asymptomatic, but the person has no symptoms, but his ejection fraction is low. This is what you will see in our clinical practice. And C is something that means somebody who has known heart disease like old MI, becomes breathless, comes to you, feels fatigued and tired. You see his ejection fraction, it is 30%. So this B and C is the majority. A is for us as clinicians to treat risk factors very aggressively to prevent them from going from A to B. And D, many a times are going to be very sick patients. They will be in ICU. They may not be remaining at home. This A and D numbers will be less, but majority is going to be between 4, B and C. Okay. Sorry, it's not moving. Okay, now try to understand. I'm going to very briefly go through the stages. Stage B, try to understand who has reduced EF. ACE inhibitor should be the best drug of choice to reduce mortality, and who are intolerant to ACE inhibitors, ARBs are appropriate. Number 2, in all patients with a recent or remote history, evidence-based beta blockers should be used. This is recommendation is 1B. And 1A is statins should be used to prevent symptomatic heart failure and cardiovascular. This is very, very important. Mind you, you guys are always learning that somebody who has heart failure or old MI, statins do not have a role. That's what is the problem. But 1A recommendation that statin should be used to prevent symptomatic heart failure and cardiovascular. This is a very, very important message. Secondly, if somebody has got severe LV dysfunction of below 30, you can probably put an ICD or a device. That's a 2A recommendation. And remember very clearly, calcium channel blockers, particularly diltiazem and verapamil, are contraindicated. It's class 3. Stage C heart failure, non-pharmacological. The first important part is fluid restriction. should be less than 1.5 liter per day, and obviously to relieve congestive symptoms. Number 2 is patient's heart failure should receive specific education. These are non-pharmacological. It's very important. Number 2 is exercise training. Regular physical activity is recommended as safe and effective for patients with heart failure who are able to participate to improve functional status. Sodium restriction is reasonable class 2A to reduce the congestive symptoms. All these things are very, very important before we enter into pharmacological management. Some people who have sleep apnea and LV dysfunction, CPAP therapy is very beneficial. And very important, cardiac rehabilitation is useful in clinically stable patients to improve functional capacity, exercise duration, quality of life, and reducing mortality. Now for all of you, you need to understand that somebody who has a HEF-REF patient which is there, just a second. In that, if it's stage C and class 2 to class 4, you need to understand that the patient should be on ACE or ARB and beta blocker both. For all who have volume overload, you need to give IV followed by oral diuretic therapies. And number 2 is if persistently symptomatic and they are African Americans, then there is something called hydralazine nitrate combination. And somebody who is NYHE class 2 to 4 provided estimated creatinine clearance is more than 30 ml per minute and potassium is less than 5, you should give an aldosterone antagonist. So the 3 drugs which have to be a part of your armamentarium is ACE, ARB, beta blocker and mineralocorticoid receptor antagonist. Over and above that, if somebody has fluid overload, then only you give this. Okay, so let's start with loop diuretics. The practical use is start with a variable dose, titrate to achieve dry weight, monitor serum potassium at frequent intervals, reduce the dose when fluid retention is controlled, teach the patient of when and how to change the dose, combine drugs to overcome resistance, and do not use alone. Means you have to use associated drug therapy. This is very, very important. If you know pharmacology, RAS pathophysiology is angiotensin 1 is converted to 2 by ACE inhibitor, and between 2 to tissue level is the angiotensin receptor antagonist where ARBs act, here ACE inhibitor act. ACE inhibitors also increase the kinins, and that is a positive effect on hypertrophy and apoptosis. Kinin like bradykinin has got protective benefit, but there is one disadvantage or side effect which is dry cough, which can occur in 10 to 20% of the Indian subset of patients. Now, when you want to talk about neurohormonal blockade, you have 2 blockages. One is sympathetic nervous system, one is renin-angiotensin system. If you block both, there is significant benefit of disease progression occurs very slowly. So we will be talking about right now RAS inhibition. And you need to understand that LV remodeling, after acute MI, the LV remodels, infarct expansion occurs and an apical aneurysm occurs. And between days to months, you see the area of apical ballooning plus thinning. This wall thickness is very good over here, and here it starts thinning. And this is called negative remodeling, which is going to be there. So ACE inhibitors have been the drugs which are very wonderful in reducing the LV remodeling. That's why they should be given very early after an acute myocardial ST elevation myocardial infarction. And drugs like captopril, lisinopril, enalapril, and ramipril and tandolapril were used in almost in early 80s and 90s. And look at the relative risk of death: 7%, 12%, no benefit, 19%, 27%, 22%. So you should understand one thing very, very important, that if you are using during and post MI, the benefit is not that much, but if they have an LV dysfunction, longer period of time if you give them versus shorter period of time, the benefit is fantastic and it's very, very great. What are the potential benefits for pharmacy guys? One is inhibition of angiotensin II formation, enhancement of the effects of prostaglandin and nitric oxide, inhibition of sympathetic activation, afterload reduction, regression of ventricular and vascular smooth muscle hypertrophy, ventricular remodeling is better, improvement of endothelial function, and reduction of proteinuria. These are very, very, very important things when you talk of benefits of angiotensin receptor blocking agents. What else ACE inhibitors do? They improve exercise capacity, functional class, attenuation of LV dysfunction, decrease in progression to chronic heart failure, decrease hospitalization, enhanced quality of life and improved survival. Great impact. Properties of ACE inhibitors based on pharmacology is that it lowers BP and proteinuria, reduces mortality and LV dysfunction, tissue selectivity by once daily dosing, dual mode of excretion. So these are the things that when you really talk about the benefit, ramipril has got benefit in across the board, enalapril and captopril little lesser. But ramipril is the one which does everything, and that is why amongst the ACE inhibitors, the best drug that has been used is ramipril. Okay. What are the practical usage points for you as Pharm D students? Start with a very low dose, that is 1.25 milligram once a day. Titrate very slowly over 15 days. Increase the dose if well tolerated. Renal function and serum potassium after 1 to 2 weeks. Avoid hypovolemia. When you are using diuretics, diuretics potentiate the effect of ACE inhibitors. Dose not determined by symptoms but by blood pressure. Combine to overcome resistance and do not use alone. What are the side effects of ACE inhibitors? Very important is first dose effect, which is called postural hypotension. Initially, you can get worsening renal function, but it stabilizes over a period of 4 to 6 weeks. Hyperkalemia, dry cough, and angioedema, which occurs very rarely. Rash, dysgeusia, and neutropenia can also occur in this. What are the contraindications? If somebody is having an angioedema, by definition of angioedema means swelling of the tongue, swelling of the lips, swelling of the eyes, and sometimes there is swelling of the vocal cords that can cause almost a stridor. Bilateral renal artery stenosis is an absolute contraindication for ACE inhibitors. Pregnancy definitely. Anybody with a creatinine above 3 mg% is again a contraindication. Hyperkalemia more than 5.5 potassium and severe hypotension means below 100 systolic. You do not use these drugs. When you talk of ACE inhibitors in heart failure, chronic heart failure, the benefit was almost 35 to 40%. And let me tell you, solid treatment versus prevention, the treatment arm had more benefit than the prevention arm. Okay. Post MI save, air, trace, and smile, you just see 19, 17, 22, and 22% reduction. This is very, very good benefit. And average is 25, so almost a 4% risk reduction control versus ACE inhibitors on mortality reduction. And remind you, this data was published in 1995, almost 25 years ago. We knew ACE inhibitors were wonderful. Now, when you talk of severe heart failure, so post-MI LV dysfunction, mild, moderate, severe, you can use these drugs where you can use captopril and ramipril in post-MI LV dysfunction. The moment they start developing congestive heart failure, you can start using enalapril, which is there. Angiotensin receptor blocker is a class 1 where they are not tolerated by ACE inhibitor, then only use them. Or they are reasonable to use if somebody, let's say, is taking telmisartan for hypertension. Now that person develops MI and LV dysfunction. Probably you can directly use valsartan in this group of patients. That's a 2A recommendation. Charm alternative. I'll not go into the trials, mind you, but try to understand candesartan yellow versus the blue line. There was almost a 23% risk reduction of this. Valheft trial also 44% risk reduction. Valsartan versus placebo, and it was in 2002. JAK. Combined mortality 13% versus placebo. This was in 2001. Charm added in candesartan had got a great benefit of 15% over a period of 3 to 3.5 years. Now we'll try to understand there are only 3 angiotensin receptor blockers which are approved in heart failure. So mind you, telmi and olmesartans are not to be used. Irbesartan has no role, iprosartan has no role, but only 3 drugs like candesartan, losartan, and valsartan. And out of them, valsartan is the only drug which is used in post-MI and post-MI with heart failure. Losartan is used in stage B as a risk in asymptomatic patients. The moment the patient becomes symptomatic, then you can use candesartan and valsartan. Very, very important. Do not use telmisartan or olmesartan in patients with LV dysfunction. There is another very interesting drug which is called aldosterone antagonist, which we call it as, there are 2 drugs which are there. One is eplerenone and one of them is a spironolactone. So let me tell you, it is recommended in standard therapy in patients who have EF below 35% and symptomatic heart failure, or somebody post-MI has EF below 40, standard therapy including ACE or ARB, the mineralocorticoid receptor. Look at the benefit, 30% and 15% in eplerenone versus this in the post-MI subset. Advanced heart failure subset, advanced heart failure subset, the benefit was far better than in post-MI LV dysfunction subset. Not recommended again, creatinine more than 2.5, but potassium more than 5, and potassium should be measured at baseline 1 week, 1 month, and every 3 months. Supplemental potassium is not recommended unless potassium is below 4. And trials with aldosterone blockade, I told you 15% risk reduction in the FSS trial, and trials was 30%. Emphasis HF was in NYHA class 2 patients, but EF below 30, 25 milligram to 50 milligram once a day eplerenone showed a significant benefit of CV death of almost 37% and 24% CV death and 42% heart failure hospitalization. And in hyperkalemia, there was hardly any difference. So what does it tell you? That this drug, when added to the armamentarium of ACE ARB or ARNI and the beta blocker, has got unbelievable benefit in mortality reduction as well as for heart failure hospitalization. Look at here, this is the placebo heart, this is eplerenone arm. You see the LV is dilated here in the cross section, here it is narrow, means the contractility has improved and it works on the elastin integrity. Look at peri-infarct patient with eplerenone, these blue sheets are very, very well preserved. In peri-infarct, these black dots are the sheets which are broken, and that results in signs and symptoms of heart failure. Okay. So somebody who has a severe congestive heart failure, spironolactone is definitely the drug of choice. And versus somebody who is absolutely LV dysfunction, post-MI and stable, you can use eplerenone. Now let's come to beta blockers. You have to understand that beta blockers during MI was used in the early days, atenolol, which showed significant mortality reduction, but this drug was contraindicated. Metoprolol in Miami and TMAB has got almost a 13% risk reduction, and third trial of propranolol had a 28% relative risk reduction. So beta blockers, one of the three proven, this is very important that in beta blockers and FRF only 3 drugs are approved. That is bisoprolol, carvedilol and sustained release metoprolol. They are recommended for all stable patients with current or prior symptoms of heart failure and reduced ejection fraction. And I will not go into the trials, but look at this yellow bar, 65%, 34%, 35% and 34% risk reduction as compared to placebo. So all the 3 beta blockers have a wonderful benefit, and it produces 34, 34, 35, 23% mortality reduction when they are used as compared to placebo. Now let's talk about a practical aspect. Start when the patient is stable. No physical evidence of fluid retention, no need for IV inotropic support. Start ACE inhibitors and diuretic first, no contraindication or in hospital or not. Dosage should be bisoprolol 1.25 to 10 mg in 24 hours, carvedilol 3.125 BD to 25 BD, metoprolol tartrate 6.25 to 75 milligrams, and 12.5 to 25 milligram metoprolol to max of 200. Start low, increase very, very slowly, increase the dose every 4 weeks, not earlier than that. What are the adverse effects of beta blockers? Hypotension, fluid retention, worsening heart failure, fatigue, bradycardia. Please review other treatments like diuretics, reduce the dosages unless required. Consider cardiac patient pacing if and discontinue beta blockers only. So if somebody has got COPD but there is no active bronchospasm, then definitely beta blockers can be given. See, this is written, reactive airway disease like asthma, AV block unless pacemaker, symptomatic hypertension or bradycardia, and diabetes is not a contraindication. Which are the 3 drugs? Interestingly, look at carvedilol is used in both. Metoprolol tartrate is used post-MI, succinate in stage C, and bisoprolol only in stage C. Very, very, very important. Hydralazine and nitrate, it's a class 2A recommendation. It's a fixed dose which can be given. And the next, the most important drug that we are going to talk about is angiotensin neprilysin inhibition versus inapri, which is the Paradigm HF trial. it tells you that ARMI 400 milligram daily versus 20 milligram LRP. It's specifically designed to replace current use of ACE inhibitors and ARBs as the cornerstone of the treatment of heart failure. The design trial not go into the details, but let me tell you, it was proven superior to ARMI in all the aspects in the primary endpoint. 20% reduction of death or hospitalization. At the same time, cardiac death also reduced by 20%. And hospitalization of heart failure was decreased by 21%. And all-cause mortality also decreased by 16%. Quality of life score also was much better with ARMI compared to this. And obviously no other reasons for discontinuation of drug therapy. Now look at this, angiotensin reduces mortality 15, this one 18, this is 18 plus 20, 38% mortality reduction. Very, very important. AHEFT is hydrolazine isosorbide dihydrogenate versus placebo has got greater benefits in people with renal failure. Ivabradine is one of the interesting and one of the best drugs that has come into the Indian market for heart failure with reducing. It is a funny current inhibitor or IF inhibitor, which is only reducing the firing of sinus cells and reduces the heart rate. This drug, in addition to added to beta blockers, is also additional benefit is there. For the primary composite shift, the effect of ivabradine was not significantly associated with baseline dose of beta blocker treatment. Now coming to the neurohormonal treatment therapy, you have all of them, beta blocker, ACE inhibitor, all that I will not go into, number needed to treat also. So what is the ideal prescription? I'm sorry. Number 1 is tablet Cardase 2.5 BID, Cardivas 3.125 BD, Eptas 50 OD, Isolazine twice a day, Lenoxin once a day, Corlan twice a day, fluid restriction less than 1.5 liters, salt restricted diet and moderate exercise. And device therapy, whoever is included, they can probably. So in patients with LV dysfunction, one very important thing is combined use of ACE inhibitors and beta blockers is the recommended cornerstone of therapy. Modest incremental benefit may be seen with addition of other antagonists like RAS inhibitors in post-MI and in chronic heart failure, while neurohormonal interventions reduced morbidity and mortality across the CV continuum. Post-MI and heart failure patients with LV dysfunction still have a high rate of sudden cardiac arrest. Okay, so I think with this I end the presentation. If there are any questions, which I believe many of you, we wanted to basically have a more of an interactive session. So I think we can take up the questions and let me know if, only one drug which probably I didn't cover was the role of digoxin in patients with heart failure with reduced ejection fraction. And digoxin now is the 5th agent which is there, but only in patients who have a LV dysfunction and have atrial fibrillation is where Lenoxin today is useful. And you need to look at the side effect profile of Lenoxin, because many patients can have gastric side effects, extracardiac side effects like hypothyroidism and hyperthyroidism. And that is the drug. And diuretic we've already discussed, which was there, in which obviously, which kind of loop diuretic you want, what dose you want, all that probably we can discuss. Okay, thank you very much for the patience. So I think Aishwarya, if the questions you need to ask them to put them into the chat box and we can take it one at a time. If there's any question, we probably will be happy to discuss that.
So, yes, sir. Thank you so much, sir, for such a wonderful session. Kuldeep, I would request you to proceed with the question and answer session.
Where will be the questions there given? In the chat box,
Kuldeep?
do we have? Okay,
Yes,
I
sir.
think we already have
Sir, I'll
questions.
take it up.
Yeah, please.
So
Yes,
there's a
sir.
question. So usually combining ivabradine with beta blocker causes sinus bradycardia.
Okay, so one thing we need to understand that beta blocker has to be started in a very low dose, let's say 12.5 milligram and up titrate till a level comes when your heart rate either goes below 60 or you have blood pressure which goes below 100. If you have this issue, then you cannot up titrate beta blocker. But when you have a patient who at 12.5 milligrams has got a heart rate of around 75, but a blood pressure is 100. So in this patient, BP is controlled, but pulse is not. So these are the subset of patients in whom you should use a evabladi, which will help along with the beta blocker to reduce the heart rate. And your target heart rate in people with heart failure should be below 70 or between 65 to 70 is optimal. I think combination you need to be careful, look for bradycardia. But if you're able to tolerate that, and what I do is I tell all my patients to monitor their blood pressure and pulse over a period of 1 month, morning and evening twice. So almost I get 60 readings. And on those 60 readings, we can then take a call as to whether I need to escalate or de-escalate the drug therapy which is there.
Yes, sir. Thank you, sir. One more question is, what are the newer drugs which are used in heart failure treatment?
Okay, newer drugs, I think ARNI, angiotensin receptor neprilysin inhibitor is one of the wonderful drugs. For your subset, I did not select that drug, but since you have brought out that question, SGLT2 inhibitors in today's era are also drugs to be used in patients with heart failure, with which I have already started using it over the past 1 year. You have drugs like empagliflozin, canagliflozin, and dapagliflozin. DAPA is a drug which can be used in non-diabetic heart failure with reduced ejection fraction, whereas EMPA and CANA can be used in diabetic with heart failure with reduced ejection fraction. They have got wonderful mechanism of action which I would not want to go through, but please read the physiological benefits of angiotensin of SGLT2 inhibitors. Next new drug, if you are asking me, is the role of intravenous ion therapy in patients with heart failure. You have something called as ferric carboxymaltose, which is available as a 500 mg and a 1 gram injection, which can be given over a period of 30 minutes. And this is in people who have iron deficiency anemia in HFrEF, not necessarily anemia. So if I have a hemoglobin of 12, but I am iron deficient, I'll still give this injection. Vis-a-vis somebody whose hemoglobin is 8 and is also iron deficient, he definitely deserves it. So these are the two new drugs like intravenous iron, SGLT2 inhibitors, which are the latest on board to add to your armamentarium of so many drugs which are there.
Another question is, telmisartan is usually used in my practice setting. Why is it not advised to use olmesartan in heart failure?
Oh, let me tell you very clearly, a take-home message is telmisartan and olmesartan are not to be used in heart failure with reduced ejection fraction. That's a contraindication. If imagine somebody is taking telmisartan for hypertension and that the gentleman develops a heart attack and EF becomes below 40, then you take off the telmisartan and use valsartan, or in today's era we have ARNI, sacubitril valsartan combination, which probably will be fantastic benefit and great improvement in LV ejection fraction and quality of life.
So, just to add on to this question, sir, can you please also tell about the prerequisites, like before starting with the RB, what has to be done? Like if the patient is on ACE or ARB, what is the time duration in which we'll have to stop the drugs?
Okay, good point. I did not discuss that aspect. If somebody is on an ACE inhibitor and you want to start ARNI, there should be a 36 hours washout period should be there. So if I have taken the first or the last dose of ACE inhibitor at 9 a.m. in the morning today, I will take the first ARNI dose tomorrow night at 9 p.m. or to be on the safer side, day after tomorrow morning, that will be 48 hours. So 36 hours is minimum, 48 hours is maximum. And the dosage of ARNI will be depending on what ACE inhibitor dose you are using. ARNI is available as a 50, 100 and 200 milligram tablet. So if somebody is on 5 milligrams of enalapril, takes 50 BID of sacubitril valsartan, 10 milligrams is equal to 100 twice a day and 20 milligrams is equal to 200 twice a day. but you can start as low as 25 BID, that is 50 milligram, half tablet in the morning and half in the evening, to start off in people, and you can then gradually up titrate slowly over 4 weeks, and you can go and escalate that. Correct. Good question.
So there's
One
one
more
more
question from
question.
Zoom.
Yes, Pooja, please continue.
What is the most important thing to do after a heart failure diagnosis?
Number one is, if you have diagnosed somebody as a heart failure with reduced ejection fraction, first job is to send them to a specialist. Particularly the specialists are electrophysiologists, who in their clinical practice are going to be. So this is what is important. Second part is, the moment they reach there, you always need to talk about non-pharmacological therapy first, fluid restriction, salt restriction, and start the drug therapy, what we discussed. And 2 or 3, 4 important things that I tell my patients as a practical viewpoint is, your fluid has to be restricted. Do not climb staircase. Do not take coconut water or banana, because they have a very high potassium content. And the last is, do not strain while passing motions or urination, because many of them will produce a Valsalva like maneuver and they can develop sudden cardiac arrest and mortality. So these are 4 things at home you should tell them. Monitor their weight, monitor their blood pressure and pulse regularly, motivate them to walk very regularly, because many of them are very depressed. So you'll have to probably tell the family members to motivate them, because most of the times they are very depressed. And these patients, do not restrict anything in their food habits. Heart failure with reduced TF has nothing to do with food habits. If I take more of fat or carbohydrates or protein, that's not relevant. But avoid potassium containing substances and avoid fluid and salt. These are the 3 utmost important. Another interesting point is, if somebody who's a sophisticated patient comes to you, one of the high contents of potassium is noted in broccoli. So avoid that person to take broccoli in their diet. That will also probably protect them from developing hyperkalemia.
The fluid restriction, like how do you individualize it for patients? Like, is it based on their weight, or do you consider some other factors also?
Okay, weight reduction is to be dependent on the ejection fraction. If my EF is 40%, intake will be 1.5 liters. If it's 35%, 1.2 liters, 30%, 1 liter. Anything below 25 or 20% is 800 ml per day. So this is all inclusive of tea, coffee, and the water that you take throughout the day. Easy method to tell the family is, keep 1 liter of bottle besides you. And generally, most of them should take only 700 or 800 ml. Rest can be taken with tea or coffee or whatever you're going to take along with that. But yeah, fluid restriction. And what you should do is, about fluid restriction, somebody is very much dehydrated because of diabetes. They get a lot of dryness. Tell them that small glasses which are available, buy them, because when you take a glass of water, you don't know how much are you taking. So this will at least be calculative, and you will take small sips rather than taking large quantity of fluid. But I think that's one of the highlighting points, that if you reduce fluid, the hospitalization rate of these patients is reduced drastically.
Thank you so much, sir. So if you have time, can we take up a few more questions, sir?
Yes, please. Yes, please. No issues. We have time.
Yes, sir. One part. Yes, sir. Thank you so much, sir. One participant has asked, usually ACE inhibitors or ARBs are stopped when serum creatinine is high. But still, like in the guidelines, usually we find that in CKD patients, ACE and ARB are the first choice. So, sir, like, can you please comment on that?
Okay, so one point that you all should remember is, ACE inhibitors and ARBs are the drugs which prevent progression of renal disease in patients with diabetic nephropathy. But there is a particular cutoff. If my EGFR is below 30 ml per minute, then those group of patients will worsen because my renal reserve is not that much. So when I give an ACE inhibitor, my renal perfusion pressures decreases and there is worsening of creatinine which occurs. So one of the simplest thing to do is you give an ACE inhibitor to that patient, and that patient, what we are supposed to do is you have to tell them that if in 3 days time, if my creatinine rises by 25%, that is the time that you should stop the ACE inhibitor. Otherwise, that person is going to have a problem and the person can have a worsening renal parameters. Just a minute, Aishwarya, one call I'll do.
Yeah, sure, sir.
Yeah, Aishwarya, go ahead.
A question from Zoom. Does ferric carboxymaltose will it increase the iron overload and restrict and lead to restrictive cardiomyopathy, which is similar to some of the iron preparation which occurs in some patients?
Yeah, so good point, but you need to understand that for the criteria, you need to do serum iron, TIBC, and transferrin saturation. That's one of the criteria. If TSAT or transferrin saturation is below 20%, means I'm sure that the person is suffering from iron deficiency. So probably that is one of the reasons that before starting this drug, you confirm what is the serum iron, so that there is no chances of overload. And this drug is to be given as a single bolus of 500 mg or 1 gram, depending on the TSAT values and the hemoglobin levels. So I don't think it can cause restrictive cardiomyopathy, provided you are being easily watching it carefully and you are managing it.
Yes, sir. Is there any difference in treatment in the current COVID era in heart failure patients?
In the month of May, there was a paper which was published that ACE inhibitors and ARBs, they probably worsen the outcomes if they are used in patients with heart failure. But there was a very interesting NEJM update in the month of June, which they clarified that if the patient is on ACE inhibitor or ARB, please continue. There is no excess mortality in them. And these group of patients do very well, irrespective of taking or not taking. Rather, ACE inhibitors, ARBs are going to be protective to the heart, and thereby these drugs should be continued even if they have COVID, unless obviously there are contraindications like renal failure and other parameters. But no contraindication. You can continue the same drug in the COVID era also.
Thank you, sir. At what stage during the treatment do we decide to go for implantable devices such as ICD and CRT? And do we give any specific medications after that?
Okay, so that's a very nice question. When we talk about CRT and ICD, there are two criteria. Somebody should have an ECG of left bundle branch block. I didn't go into intricacies because there was a lot of ECG involved. So the person should have a left bundle branch block, wide QRS more than 150 milliseconds, ejection fraction below 40%, symptomatic despite optimal medical therapy, and LV dilatation of more than 55 millimeters size. If these criteria are fulfilled, patient is on very good drug therapy, still symptomatic, then CRT is the treatment of choice. ICD is to be used in people who probably have got sustained monomorphic VT, and these patients, for reduction of sudden cardiac death, ICD is recommended. When you talk of combo device, means CRT plus ICD should be used in younger people, people with probably less comorbidities, less symptomatic, right ventricular function is very good, the person does not have significant mitral regurgitation. Mind you, these are all technical points, but at what stage means if despite optimal medical therapy of 3 months, if patient is still symptomatic and they fit into the criteria of CRT, then probably this therapy should be advised to the patients because the cost of this entire procedure is close to 5.5 lakhs. So if they are affording, we should tell them. If they are non-affording, then too we can inform them so that today, tomorrow, if they get their finances ready, we can probably do that. So this is the stage at which probably you can plan an ICD or a CRT in these patients.
So to follow up on that question, do we give any specific medications after the implantation
No,
of such
medication is the
device?
same, my dear. No change. I have to just continue optimal medical therapy with whatever drugs I am taking, and the device will be there inside. Yes, I should follow up with a 2D echo every 2 monthly, 3 monthly to know what is happening to the heart size, what is happening to the mitral regurg. Then there is something called AV delay, VV delay. Optimization can be done echocardiographically. But these are all technical pointers. But yes, there are no special medicines to be given once they are on an ICD or a CRT or a combination of ICD and CRT.
Another question. What will be the drug of choice for fluid overload in patients in whom diuretic is contraindicated, like patients who are taking lithium for mood improving pills?
Again, come back. I didn't get it. I'm sorry.
What will be the drug of choice for fluid overload in patients who are contraindicated for diuretics?
No, so I don't feel lithium or something. You have to give them intravenous diuretics, particularly torsemide or furosemide. Depending on that, you either give bolus or you give drip. Even if the patient's creatinine is high, fluid overload cannot be reduced by no other drug other than a loop diuretic. Be prepared that the patient's preload is going to decrease and the creatinine is going to rise, but symptomatic relief can only come from loop diuretic.
Thank you, sir. One more question is caffeine good for patients with heart failure with reduced ejection fraction?
No, I would say caffeine is going to increase your heart rate. So caffeine in higher forms is not a very useful component in heart failure. Rather, it may worsen, not symptomatically, but yeah, if somebody is taking coffee very frequently, it's not a good sign. So technically, I believe it's a relative contraindication. Not that nobody can take caffeine, but caffeine has got increased heart rate chances in patients with heart failure.
One more question is how efficient are biomarkers in determining heart failure development?
My God, you guys have read quite a bit, Baba. You're talking about biomarkers. Wonderful question, but yeah. So that also I didn't cover because I thought maybe the scope of the topic is more of students or maybe you're just early passed outs that we discussed. But biomarkers are absolutely relevant in heart failure diagnosis, prognosis, and therapeutics, all the levels. Three biomarkers you guys should remember. One is troponin T or troponin I. Number two is NT-proBNP, N-terminal pro-brain natriuretic peptide. And the last is now a new biomarker called ST2, soluble protein ST2, which you call it at. S small and then ST2 capital. ST2 is a marker of fibrosis. So if somebody, let's say 10 people are with the same ejection fraction of 30%, I want to prognostic with which one is bad, who can die suddenly, will all depend on the amount of fibrosis of the ventricle. Higher the fibrosis, higher the chances of mortality. So ST2, if it is high, has got a short-term or a long-term mortality very high, which is normal. Imagine ST2 is normal, mortality is better. Number two, NT-proBNP is used clear-cut in casualty. If somebody comes with breathlessness, I do NT-proBNP, I don't have an echo machine, I will differentiate pulmonary from cardiac cause. Anything below 500 is normal and anything above 500 is abnormal. Then comes the troponin T. Troponin, we always were taught in our undergraduate and postgraduate days that this is a marker of muscle injury. Somebody has an MI, trop T is increased. But there are subset of people where there is a significant myocardial stretch And TROP-T elevated in a person with heart failure versus normal TROP-T. Higher TROP-T has got worse prognosis than a normal TROP-T. So biomarkers should be repeated. When I have fluid overload, my NT-proBNP is 4,000 or 3,000. The moment my fluid overload goes away, and I am pre-discharged when I do NT-proB, if it comes down to 2,000 or 2,500, means my NT-proBNP has come down. So these are the markers that you should judiciously use in your clinical practice, which I do it very regularly as a heart failure specialist. And we probably have got wonderful role and usage of biomarkers in clinical practice in heart failure with reduced EF. But a wonderful question here. I didn't know you guys are more well-read than I was prepared. Excellent, excellent. Good questions.
Thank you, sir. So that's all with the question and answers. Thank you, sir, for delivering such a marvelous and an enlightening session. And on behalf of the Pharm D community, I want to thank our speaker, Dr. Rajesh Badani, sir, for delivering such a marvelous and enlightening session. Thank you, sir, for taking time out of your busy
There are
schedule,
no
even in
issues.
this pandemic, to deliver us this
No,
session.
I first of all should thank both of you, you and Aishwarya, really behind, because last week there was some technical glitch. I don't know, because maybe my PPT was not opening, but looking at the questions, I don't believe you guys are anyway less than any of your medical fraternity counterparts like BAMSs or BHMSs or your MD medicine guys also, because I believe you guys are really read very well, and all the questions that I found, I had not expected this, so it was more of a surprise to me. But I'm really happy that Pharm D level is really rising much, much, much better, and I hope you guys are a great asset to whichever organization in future you join, because I believe a combination of a pharmacist and a clinician can really break all shackles and barriers, and probably you can do a wonderful job as a team of a pharmacist and maybe a clinician both put together. I am a very strong proponent of that, and I believe community medicine is going to remain alive only by you people and we people when we join hands together, but which most of the institutes don't do that. But at ABMH, I am really happy and proud that to say that I think we have done this repeatedly, and this year I believe Pharmacon was not possible because of maybe our pandemic part. Maybe next year, hopefully, we should have a wonderful meeting. But I am really impressed with all of you. I think thanks all of you. I think how many of them you are there. It's an excellent attendance, and I hope that this meeting at least enlightens you and takes you towards little more of clinical pharmacy and reading the drugs. So please, one advice is do not read pharmacy just like that, because I remember in my second MBBS also we had pharmacy. But when we used to read Satoskara and all the other things, we realized that when you implement it with, because Pharm D means pharmacy put into clinical practice. So the moment you see a patient and you talk about a drug, that is one of the best things, because that combination helps you a lot. So as interns, we were like you people. I used to go to a ward of CKD and dialysis, and we used to look at all the prescription. Then we used to audit why this drug in a CKD patient, why not this. And maybe we learned a lot, and that helped us in our future days. But be a good clinician, be a sound clinician. You are an asset to the pharmacy community, and PharmD students should really do good when you are in unison with the clinician together. And I hope someday we will have an area where pharmacist and the clinician will be working together as a team. They'll be doing wonders, I believe. So that's not, the time is not far away from this end, and hopefully you guys now are so active that probably I hope this you'll achieve this soon. Okay, and thank you very much for having invited me to speak on this topic.
Yes. Thank you, sir, for your motivating words. It will really has motivated all the participants, I'm sure, to really pursue clinical pharmacy and get a good job. And lastly, I also want to thank all the participants who have attended today from all over the country. Thank you so much for coming, and I really hope that these sessions help you in your clinical postings. Thank you so much, everyone.
Sure. Thank you. Bye-bye. Thank you very much. Bye.
Thank you, sir.
Yeah, sure.
Bye, sir. Thank you so much, sir.
Thank you.